As usual, if you use a Mac, there's the usual problem. So this is not unexpected. Although the topic that was assigned to me this morning is on bone and joint infections, other than a group of orthopedic surgeons, this is the group who I would say would be most interested in bone and joint infection. A group of pediatricians who are interested in infection. Why? Why should we be interested? First, if we look at the numbers, when you look at acute osteomyelitis, approximately half of them would occur during the first 5 years of life. And mind you, 85% of all hematogenous cases will occur in kids. So that's very, very big. At the same time, if you look at septic arthritis, this would occur in patients, in half of them, half of septic arthritis would occur in patients less than 20 years old. And look at the peak, it's at 1 to 3 years of age. So this is the demographic group that we are all interested in, me being a pediatric orthopedic surgeons and you as pediatricians. Other than the numbers, we look at the outcomes. If we fail to recognize or treat osteomyelitis properly and early, most of the time it would resolve if properly treated and early. But unfortunately, chronic infection may ensue. And what happens if we have chronic infection of the bone? We have a huge number of possible problems causing disability. Example is this patient of mine. He's 4 years old, and around age 2 years, he had this massive osteomyelitis which involved the entire tibia. And this is his x-ray. And you can see the entire tibia is gone. What happened to his limb? It is short, it is deformed, and there's an angular deformity, and it's non-union. There's a non-union, it's not united, it's wobbly. The patient cannot stand on it. And good for this patient, there's no chronic draining sinuses, which some patients would have. So the possible outcome, if we don't treat this bone infection properly, is quite big. What do we know about osteomyelitis? We know that this is often hematogenous, and usually it would involve the bones around the knee, the distal femur and the proximal tibia. Why? Because if you look in the body, this is the area with the largest ossification center. A lot of blood goes there. Okay? And why in kids? Probably there's a lot of it would be because of the factors, the host factors. Why are kids are vulnerable to infection? And also at the same time, they say when we look at the vascularity of this area, there's a sluggish flow of blood, making it more static. The stasis of the bacteria, allow it to settle here in this area. And it's said that in this area, the phagocytic activity is much diminished. So this area would be very vulnerable to onset of acute hematogenous infection. And at this point, Staph aureus is still the main bacteria involved in acute osteomyelitis. And if we look at the different age ranges, periods, there would be some certain bacteria which will be more predominant. But this is, we always look at it as this changes in the pattern. Especially now, if we look at the pattern now, let's take a look at this paper coming from Glasgow. This is a first world country, and it showed that there's a decreasing overall incidence of osteomyelitis over the years. This is a study of over 30, 40 years. And there's a decrease in long bones, and other areas are the same. Though Staph aureus, it's decreasing. But unfortunately, it may be decreasing, but we have another problem. there's an increasing or rising incidence of MRSA. Unfortunately, in the country, I'm not so sure if the picture I've shown earlier, which is in the first world, would hold true for our place here. I wonder if the incidence of infection in bone is also decreasing. Probably not. Unfortunately also, that problem, plus we also have this problem of rising incidence of MRSA. Some centers have already cited from 20 to 40% of incidence of MRSA, and some would even cite a 50% incidence. So this is very alarming. And how do we classify or try to compartmentalize osteomyelitis? Because this would help us in formulating our management, and also prognostication would be helpful. The old way would be by Vogel, where he divided into acute or chronic, or based on the source of the infection, or whether there's a vascular insufficiency or not. Nowadays, we would probably prefer using the Scherning-Maeder staging system, and this is the system wherein we have two components, the anatomic type and the physiologic class. So here, the anatomic type will only tells us what part of the bone is involved, whether it's the medullary cavity only, or it's only at the superficial portion of the bone, or if it's only a localized portion of the bone involving the medullary cavity and the cortex, or if it's a diffuse form of osteomyelitis, so much so that the integrity of the bone is compromised, meaning that it's about to break or it's already in a non-union and it cannot withstand weight bearing. So that would be the diffuse osteomyelitis or stage 4. But nice thing about this staging system, it takes also into consideration the host. Here, it classifies the host into A, B, or C, where A is a normal host, B, there's some compromise, and C, as you look at C, treatment is worse than the disease. So if you classify using this staging system, it would be either a 1A or a 1B or a 4A or a 4B, and so on and so forth. How about the unusual osteomyelitis? It may present not just as one focus, it could be a multifocal. We've seen it frequently here in the country, especially in malnourished and those patients with immune deficiencies. It's not unusual to find, say, an osteomyelitis in the proximal tibia and at the same time an osteomyelitis in the proximal humerus. There's another entity which can confuse us, or the so-called CRMO, or the chronic recurrent multifocal osteomyelitis. This one is not bacterial in origin. They say that this is autoinflammatory and usually would have multiple focus. Sometimes they would occur not at the same time, but at different periods. And there would be a prolonged clinical course over years with exacerbations and remissions. But overall, if we follow them, there's no long-term sequelae in most of these patients. And treatment, we don't know how to treat them really. Microbials, antimicrobials are useless. Your interferon, they say, is very, very minimal effect. Steroids has also very, very minimal effect. On its own, it would resolve on its own. Okay. And X-ray would present something like this. This is a patient of mine around 2 years old. Initially, both femur, and then later, 6 months later, we noted the tibia being involved. But that was what, 10 years ago, the patient came back, no problem. So how would we diagnose a typical acute osteomyelitis? The key is good clinical history and good physical examination. That's the bottom line. And we should have a very high index of suspicion. Why? If we look at the studies, most of these cases would present with very, very vague symptoms. 50% of them would present with very vague symptoms. Some would only present with lethargy, some form of irritability, some fever, or sometimes a child would present with what we call a pseudo paralysis. I have this case long time ago. It was good that the mother was quite intelligent. She saw that the child was not moving her arm, his arm. You hold onto the arm, the child would just let it drop. And if you try to move it, the child would not cry. So you would think that this is some form of a neurologic paralysis. But because of the high index of suspicion, we took a bone scan. And lo and behold, we found infection in the proximal humerus. This is what we call a pseudo paralysis. So do not be confused if the symptoms are very vague and totally disregard the possibility of an acute osteomyelitis or a septic joint at that. So if you are presented with this possible septic arthritis or rather acute osteomyelitis case, what do you do? What do you request for? We usually would request for parameters of inflammation like ESR, CBC, and CRP. Nowadays, we use the CRP, the quantitative form, not the qualitative form that some hospitals or laboratories would give us. Because we find that CRP is more predictive of the outcome. They say that if you have an elevated CRP after 4 days of treatment, then most likely your case would be a complicated case. And I'll show you later how would this affect more or less your treatment. And cultures are very important. Remember, take the cultures before giving the antibiotics, the blood culture, And cultures from the sinuses, if the patients have draining sinuses, are actually useless. The best would be to get specimen from the bone itself, deep specimen. So if we are already dealing with chronic osteomyelitis, not the acute form, we suggest that we have an antibiotic holiday of around 3 to 4 days so that we would have a better yield. Now, we go to the imaging. You've already requested for the laboratory exams. Now you are faced with the problem of what imaging will you request. You have this long list of possible imaging modalities: X-rays, ultrasound, CT scan, MRI, bone scan, FDG, PET scan. Let's go first to the cheapest and most available, which is X-ray. Unfortunately, it may be cheapest, but it's not so useful during the first 10 to 14 days. Why? Because there's a lag by as much as 2 weeks. The presentation in X-ray will not, the X-ray picture of acute osteomyelitis will not present during the first 10 to 14 days. At the most, around that time, around 10 to 14 days, you'll probably just get only some periosteal reaction or focal osteopenia. And the same way, your patient may already be responding. You take an X-ray, and then you'll find that the X-ray is becoming worse. So the evidence of recovery also lags behind. So unfortunately, I've seen some cases who were seen in the emergency room and were sent home. And osteomyelitis was ruled out based on an X-ray. And then the patient came back, and lo and behold, the entire bone or entire tibia was already showing signs of infection. And it's already a chronic form of infection if you see those radiologic signs. Now, how about ultrasound? Is it useful? It's useful not because we can view the bone, but we can view the soft tissue around it, particularly if abscess is forming. Okay? And that could help us, guide us where to aspirate. So in that aspect, ultrasound is something that we should entertain, especially if the case is becoming a complicated one. A CT scan can also be helpful, but it's not so useful for acute osteomyelitis. It may be useful for chronic osteomyelitis when you want to see where the dead bone is. It has the same limitations as your X-rays. So when you are confronted with an possible acute osteomyelitis case, the CT scan may not be the best imaging to ask for. MRI at this time is what we would consider a gold standard for imaging. It would present us the soft tissue, show us the soft tissue and the bone condition. At the same time, this is what we call a physiologic form of imaging. So you don't have that log time, that huge log time that X-rays have. So in 24 to 48 hours, you should be able to see changes using your MRI. You also have the possibility of using your bone scans. Remember, this is also something like a physiologic imaging, so you can get early findings. Unfortunately, it's not specific in the area where you want or you're zeroing in, but it helps if you don't know if it's only a single focus or a multifocal form of osteomyelitis. You can use your bone scan. And you have different forms of bone scan. How about the PET scan? Of course, we all know that this is usually used for tumor. Unfortunately, it's not so cheap, but it can be used. And in a study, it has been shown that it has the highest accuracy compared to the other modalities when it comes to chronic osteomyelitis. Now, here is more or less a graphic presentation of how we would use the imaging modalities that we have at hand. Let's say you have a suspect osteomyelitis. The first thing that you could ask for is a plain X-ray. If it's negative, with localized pain, and if in the area is an area where there's a high prevalence of your MRSA, then you probably think of asking for a bone scan. But if it's already positive, of course, you go for immediate therapy. But in case that bone scan turns out to be negative, and you still can, this is the modality that you can use to more or less to rule out the possibility of osteomyelitis. Your MRI, if it's positive, of course, treatment. And then, of course, if it's negative, you have to assess your clinical findings. So here, you use your MRI more or less as parang backstop to see whether if it's really acute osteomyelitis or not. But since the bone scan could provide you with, of course, it's cheaper, it's easier to use actually, you don't need to sedate the patient, then that might be a better option in cases wherein you are not so sure of your diagnosis. Now, when it comes to treatment of acute osteomyelitis, the mainstay, I would repeat, is antibiotics. Early giving antibiotics early on, and that's the mainstay. Surgery would come in as a secondary form of treatment if the case is becoming complicated. So you would have to give an initial empiric treatment, of course, after getting your bone blood cultures, but you have to modify it based on the pathogen that is most likely appropriate for that particular age and in your area of practice. Let's say MRSA is so prevalent in your area, maybe you should be giving already some anti-MRSA agents. And best would be if you can have antibiotic treatment which is culture guided. At this point, there's no consensus or strong evidence regarding the route and the duration of antibiotics in acute hematogenous osteomyelitis. Years ago, we would say that let's have a 6-week course, but now that is being questioned. So there are a lot of variables that have to be considered whether you're going to give this long duration of antibiotics or you go for a shorter course. At this point, it's not yet clearly delineated. But you can consider this recommendation from Professor Wilkins from the University of Texas, a shorter antibiotic treatment if the duration of symptomatic pre-treatment is short, less or equal to 10 days, or there's a rapid and complete resolution of clinical signs of infection within the first week of treatment. And if CRP normalizes within the first week of treatment. So these are some factors that you can consider if you want to lessen the amount of antibiotics that you're going to give. So more or less, this is how we would treat the patient. You have a culture-guided antibiotic treatment. You get this initial antibiotic selection. Then, based on the culture, you change it, of course. And then, if you have a poor response, then that's where surgery comes in. Poor response means that in 48, 72 hours, the patient is not showing any signs of improvement. And that may be because you may have some abscess formation which needs to be drained. The infection you have to bore holes through the bone so that it could be decompressed. And so that's where surgery would come in. Otherwise, if the response is good, then, as I mentioned earlier, antibiotics, antibiotics, and antibiotics. So in surgery, when it comes to surgery, the basic principles that we would follow is that if you have pus, you drain it. You have to drain it. And there are dead tissues, dead bones, you take them out. If there's a dead space, you obliterate it. And if the bone is exposed, you cover it with some form of soft tissue so that the blood will be able to reach those exposed bones. And those are the basic principles in surgery when we do surgery for osteomyelitis. When it comes to chronic osteomyelitis, we know that the sequester or the dead bone is the nidus for the continuous proliferation of the infection. So that has to be removed. Years ago, we were a little bit timid when we take out the bone. Why? Because we are not so sure how we are going to reconstruct the bone. Nowadays, we can resect it as much as we want, remove all of the sequestra, and then we can reconstruct the bone by what we call Ilizarov surgery, which I do. Like this in this case, there's a huge gap here. We put this Ilizarov ring, there's a fragment here which we cut here, and then we bring them together. So the space in between that was previously occupied by the sequestrum is now obliterated. And that gap that you produce by this method, you what we call regenerate bone. So you now reconstitute the leg or the bone segment using this Ilizarov form of surgery. But there are times when surgery is not possible. Remember, in this Schoening-Mader staging, there are instances when the host is better off not being treated by surgery, and that's the time that probably suppressive antibiotic treatment is called for. So the ideal drugs, of course, would be those with good bioavailability, low toxicity, good bone penetration, and traditionally administered for 6 months. Some other findings, maybe we're looking at the possibility of combining antibiotics with some growth factors, and they've initially shown good results. The problem with glycocalyx or biofilm still there, and usually the treatment available at this point would be basically surgery to wash them off, take them off. Okay. So there's an interesting connection between osteomyelitis and septic arthritis, particularly in neonates and when it involves osteomyelitis of the femur. In neonates, there's a changing pattern of the blood supply of the bone. Normally, if you have a physis here or the growth center, that is avascular. But in neonates, there's what we call a transphyseal vessel which crosses through that physis. If you have an avascular physis, that prevents the infection from going through and reaching the joint. But in neonates, this is not so. So mind you, if you have osteomyelitis in neonates, be wary that there's increased possibility of getting septic arthritis. Okay? What about hip joints? In hip joints, this is a little bit different ang kanyang anatomy because this is the physis where the infection would usually arise. But this physis is within the joint, meaning the capsule normally in most joints will only bridge from this to this part. But in the hip joint, it bridges from here down to what we call the intertrochanteric area. So if you have an infection here, it can easily seep out and invade this joint, the hip joint. So these are two things that you should remember. And sometimes when we are presented with a child who is limping with painful hip, the question is whether this is really a bacterial form of or septic arthritis or just what we call a transient synovitis. We know transient synovitis on its own would resolve in a matter of few days. And there was a good study way back in 1999 by Cocker, and he found the predictive values, factors, and their diagnostic value in septic hips. The factors are fever, non-weight bearing, ESR of more than 40, WBC of more than 12,000. So if you only have two predictors out of these four, you only have a 40% chance of septic arthritis. If you have three, it's already high, which is at 93%. And if all predictors are present, then you have a 99.6% chance of septic arthritis. So basically, when you are confronted with septic arthritis, you have pus inside the joint. And that pus should not be allowed to stay inside. This is an urgent surgery. You have to decompress it. Otherwise, the cartilage in the joint will be destroyed by all those proteinases and also by the increased joint pressure, and it will prevent the nutrition reaching the cartilage, and cartilage will die. And we know if it dies, then you're going to have